So I have a problem. I see dead people. And they're not really dead people, they're zombies. And I see them all around me. And I think most of you see them too. And you can recognize them because usually they're wearing a white coat and they have a stethoscope around their neck. And you go to them and you say, I have heart disease. I'm worried about heart disease. And they have this strange, brain-destroying virus that the only thing they can respond is, what is your cholesterol? Is your cholesterol low enough? How do we lower your cholesterol? And you try and get them to talk about anything else. And all the virus, it's got their brain. They're like, cholesterol. So, I've started going around with my silver zombie fighting sword. And what I've found is, on that sword, I have now inscribed, heart disease is about more than the lipids. And I just repeat that back to them. Heart disease is about more than the lipids. And finally, some of them start to, wake up. I can see their eyes kind of come back alive. Their brain turns back on and they start thinking again. So, one of the things I'm hoping to accomplish today is for all of you to understand that heart disease is about more than the lipids. And my good friend and colleague, David Diamond, he's going to talk later today in very good detail about the lipids. But I challenged myself to try and get through a talk as a heart surgeon and not mention lipids. We're going to mention them a little bit, but heart disease is not about the lipids, okay? It feels good to say it. Why don't you all say it with me? Repeat after me. Heart disease is not all about the lipids. All right, so let's see what we can figure out about heart disease that might not be about the lipids. And today I'm going to focus on inflammation specifically. And we're going to talk about what is inflammation, what the role of inflammation in heart disease is, how we can assess inflammation clinically, how we can treat it, and, is there a role for reducing inflammation with a therapeutic carbohydrate restriction as part of the management of heart disease. So, what is inflammation? You can go to Wikipedia, here's kind of the definition. Inflammation, it's part of the biologic response of body tissues to harmful stimuli, such as pathogens, damaged cells, or irritants. Keep this in mind. It's a protective response involving immune cells, blood vessels, and molecular mediators. The function of inflammation is to eliminate the initial cause of cell injury, clear out the damaged cells and tissues, and initiate tissue repair. Now, inflammation can be classified as either acute or chronic. Acute inflammation is that initial response of the body to the harmful stimuli, and it's achieved by an increased movement of plasma and leukocytes from the blood into the injured tissue. And then a series of biochemical events propagate and mature the inflammatory response involving the local vascular system. Sounds like it might be important to the heart, right? The immune system and various cells within the injured tissue. Prolonged inflammation, known as chronic inflammation, leads to a progressive shift in the type of cells present at the site of inflammation and is characterized by simultaneous destruction and healing of the tissues from the inflammatory process. Keep that in mind, very important. So, looking at the differences between acute and chronic inflammation. Acute inflammation, there's a causative agent, usually a pathogen, bacterial or viral pathogen, and you have injured tissues. Whereas in the chronic inflammation, you get this persistent acute inflammation due to non-degradable pathogens, viral infections, persistent foreign bodies, or autoimmune reactions. The cell types involved vary, and we'll get into that a little bit more. The primary mediators, when you get into chronic inflammation, your mediators become things like interferons, cytokines, growth factors, reactive oxygen species, and hydrolytic enzymes. And then, obviously the duration, acute inflammation is going to last a few days, and chronic inflammation is going to go many months to years. And the outcome is really what's important, because acute inflammation ends in one of three ways. It resolves, it can become an abscess, and it can lead to chronic inflammation. And the chronic inflammation then starts to lead to tissue destruction, fibrosis, and necrosis. All things that are going to be very important in the development of atherosclerotic heart disease. In the late 90s, Frankeschi and his group defined this new entity that they called inflammaging. And it's a combination of inflammation and aging. And they describe it as a chronic, sterile, low-grade inflammation that develops with advanced age in the absence of overt infection, and that may contribute to the clinical manifestations of other age-related pathologies, like heart disease. And they kind of focus on the macrophage, which is in the center of the picture there, as the driving cell type behind this inflammaging. And heart disease, obviously, being the leading killer in the United States, and its incidence is closely related to age, increases, with age. Cardiovascular disease is really the hallmark of inflammaging. So the concept that inflammation is involved in heart disease is certainly not a new one. The work of Virchow and, all the doctors out there will remember Virchow's triad, lectures given in the mid-1800s here on a more precise account of fatty metamorphosis. So Virchow was actually fighting the same battle 170 years ago, saying that heart disease wasn't about the fat. It wasn't about the lipids. Yes, we cut up the blood vessels of people who have died from heart disease and we see this fat in there, but it's not about the fat. It's not about the cholesterol. He said that we can distinguish a stage of irritation preceding the fatty metamorphosis, comparable to the stage of swelling, cloudiness, and enlargement, which we see in other inflamed parts. Who remembers, the first century BC, Galen, rubor, dolor, and color, redness, pain, and swelling. This is the classic signs of inflammation. And he goes on to say, I have therefore felt no hesitation in siding with the old view in the matter. Remember, this is 1858. He's talking about the old view and in admitting an inflammation of the inner arterial coat to be the starting point of the so-called atheromatous degeneration. So again, 1850, he recognized that inflammation is the inciting event. It is the root cause of atherosclerosis, and he was already fighting the battle to say it's not about the lipids. So more modern times, there has been a resurgence in this concept about inflammation and atherosclerosis. Peter Libby is probably the most prominent out of Harvard, who has kind of led this charge, 1970s, 1980s, 1990s, to describe the inflammatory process that's involved in atherosclerosis. And again, he has shown in his laboratory that the earliest event leading to atherosclerotic plaques is the active movement. It's not a passive movement. It's an active movement of monocytes across the endothelial barrier. And this starts, of course, when the endothelial barrier gets damaged. And, what does it get damaged by? Sugar is a big one. Other toxins, smoking, inflammation. Again, the hallmark of inflammation is damage to the lining of the blood vessel wall. So mononucleocytes cross over, they become macrophages, they consume the lipids. And I said I was going to try to not talk about lipids, but this is the mention of lipids in this talk. The macrophage consumes lipids, and importantly, very important thing in this diagram, modified lipids. These macrophages don't consume non-damaged LDL particles. They consume oxidized, damaged, small, dense LDL particles. And they then become what we call foam cells, and then they start to break down. They undergo apoptosis to try and resolve this inflammation. And now the problem is all these damaged lipid particles that were trapped within the foam cell are released, and they start to accumulate in the subendothelial space, the subintimal space. He's also shown that he and his lab have shown that T lymphocytes are involved in this process as well, and all manners of the immune mediating cells get involved in this process. And so then we start to get this accumulation of lipids, again in the subintimal space, what we call early atheroma. And this can now undergo one of two things, one of two pathways. It can become what we call a stabilized plaque, and it can continue to accumulate these, essentially dead lipid particles that get walled off. This site of chronic inflammation, like any other abscess, what the body tries to do is it tries to wall it off from the circulation, and it keeps covering it, and it develops this thick fibrous plaque, which has been shown to contain numerous inflammatory markers like C-reactive protein, like IL-6. And over time, if that continues to build up enough, we might now obstruct the lumen of the blood vessel and get the clinical manifestations of heart disease. Or sometimes what happens is basically we don't develop the thick plaque. This collection of necrotic debris gets exposed to the blood. It sets off a thrombotic pathway. You get blood clot. And now you have, what we usually call an acute myocardial infarction, a plaque rupture. And all of a sudden now the blood vessel is obstructed by clot. It's not obstructed by lipids. We have extensive work now showing that inflammatory markers are predictive of heart disease risk. And the most well-studied, the most well-known is C-reactive protein. C-reactive protein is made in the liver in response to inflammation. This is a large meta-analysis from 2010, and you can see the very linear relationship between C-reactive protein and the development of atherosclerotic coronary heart disease. Also associated with ischemic stroke, all vascular deaths, and all-cause mortality starts to increase once you get above a C-reactive protein of about 3. Other inflammatory markers have been investigated for their predictive value in heart disease. Interleukin-6 is probably the one that is, second to C-reactive protein and has also shown good predictive value for the development of heart disease. And, we can compare this to predictive values of lipid markers. And, many of you have seen in many talks that I've given and others that comparison. I know one of the speakers had the slide yesterday showing the Women's Health Initiative study from a few years ago. And, again, the difference between predictive for lipid markers as predictive of heart disease. It turns out that inflammatory markers are as predictive, if not more predictive, than the lipid markers when it comes to the development of heart disease. Now, of course, as we tend to do in medicine, when we identify a marker, the next thought becomes, well, can we modulate this marker? Can we figure out a drug that modulates the marker so that we can take care of, the disease process. And that works with variable success. And actually, inflammation in heart disease is a great example of how that theoretical progression from discover the marker's high, give a drug, lower the marker, does it modify the disease? Not always. So there have been a host of trials looking at anti-inflammatory medications in the effort to prevent heart disease. Most of these have been done as secondary prevention trials, meaning that the patients already had heart disease. Can we prevent a second event? There have been some primary things. Probably the two biggest trials to date that have shown some modicum of success are the CANTOS trial, which looked at basically an orphan drug for rheumatoid arthritis called cancanumab. Yeah. But it's an IL-1 beta agonist. So it opposes IL-1 beta. IL-1 beta is actually a precursor of C-reactive protein, and this drug was used is used for rheumatoid arthritis, and the company wanted to see if maybe it helped against heart disease. And then colchicine, which is a medication that has been used for many, many years for things like gout and other inflammatory conditions. Those are the two that have probably been most tested and have had the most success. So the CANTOS trial published New England Journal of Medicine. This is 2017. And what they showed was that the medication lowered CRP dramatically. So these are CRP levels. The blue line is the placebo group, and then the varying doses of the medication over 48 months, so out to 4 years, dramatic, like 80% reductions in the C-reactive protein level. They showed that basically there was no significant change in lipids in patients on the medications, and they basically showed at the highest dose that there was a significant reduction in recurrent cardiovascular events. Again, these are all secondary prevention patients that had had previous myocardial infarctions, so recurrent infarction. Now, when you look at this graph, again, it gets a little hard to separate out the placebo and the therapeutic groups, but it did reach statistical significance. I have a feeling that David is going to show a few graphs like this looking at statins that look very the same, that you really have to squint, but there was statistical significance. Now, unfortunately, the problem was that they also statistically significantly increased the risk of infection, serious infections requiring hospitalization, and so while they did meet the primary endpoint of the trial, this therapeutic agent has not been approved and has not been widely adopted for the prevention of heart disease. Colchicine, which is a cheap, inexpensive drug, more widely studied. There have been now 3 large trials. There's been the LODOCO 1 and LODOCO 2, and this is looking at LODOCO 2. So this was published more recently, 2020, I believe, and they took, again, patients with chronic coronary disease. They put them on a low dose of colchicine daily, looking for prevention of secondary events. And again, there was a what I would call a modest effect, but it did reach statistical significance. Again, though, all-cause mortality, death from any cause, had a trend towards increase in the colchicine group, didn't reach statistical significance, which has kind of tampered the enthusiasm for this. Second colchicine trial, this was the Colcott trial, where they actually started the medication immediately after myocardial infarction. So within 30 days of myocardial infarction, and again, with the hope that if you intervene earlier, you'd see a more dramatic effect. They did reach statistical significance on the composite primary endpoint, which was MACE, but no impact on all-cause mortality. And so there are ongoing trials for these medications and other anti-inflammatory medications, but we really haven't seen a dramatic effect of modulating inflammation with medications for the prevention of cardiac disease. Now, when you look at statins, one of the interesting things that we have known for a long time is that they don't just lower cholesterol. Statins actually have anti-inflammatory properties. And, this is one of the probably most heralded statin trials ever, the Jupiter trial. And in the Jupiter trial, they actually went and they did an interesting sub-analysis where they looked at patients with inflammation, with elevated C-reactive protein levels. And they selected out about 15,000 participants of the initial trial that had elevated C-reactive protein levels at entry. And then they looked at what happened to both their LDL cholesterol levels and their CRP levels. In other words, did you get lowering of LDL? Did you get lowering of CRP? Did you get lowering of both? And what they found was in the group that basically didn't reach target for either their LDL or their CRP, I guess we would call these non-responders to the medication, there was actually an increase in cardiac events. Didn't reach statistical significance, but a trend towards increased cardiac events in those patients that didn't lower inflammation or cholesterol. In the group that lowered their CRP, but did not lower their cholesterol, so their CRP goes down to below 2 is the cutoff they use, nearly normal level. Their LDL stays elevated. They had a dramatic reduction in cardiac events, almost cut in half. The group that lowers cholesterol but doesn't lower inflammation has lower event rates, but not as significant as the other group that lowered inflammation. And when you lower both, you got the most dramatic reduction in events. Now, of course, there's lots of criticisms of the Jupiter trial. The big one is probably right here, funded by AstraZeneca, the maker of rosuvastatin, and there's been lots of questions about the validity of this data, but just interesting to see that, again, most of the effect came from lowering inflammation, not from lowering cholesterol in this trial. So, all of you sitting in this room are probably thinking, well, I have a better way to lower inflammation, right? Just stop eating the chronic irritants that are leading to the chronic inflammation that are then leading to heart disease. And the impact of low-carbohydrate diets, therapeutic carbohydrate restriction and inflammation, it's actually not as well described as I was hoping it would be. So, all of the following Tro's call for us to publish more data, this is one aspect of it that we certainly want to get more data on. But the totality of the evidence that is published does suggest that ketogenic low-carbohydrate diets do lower inflammation. This is actually a rat study where they looked at IL-1 beta and TNF-alpha, showed significant reduction in the response to an inflammatory challenge. So they used lipopolysaccharide, LPS, to challenge these rats on either a baseline diet or a ketogenic diet, and they showed that there was a significantly blunted inflammatory response to the challenge in the rats on a ketogenic diet. Looking at humans, this is a small trial that looked at the regulatory effects of ketogenic diets on the inflammatory response in obese Saudi women. And what they showed, obviously the significant reduction in weight, waist circumference, and BMI in these women. And then they showed that their baseline IL-1 beta levels were cut very dramatically from 121 down to 20 in 30 days on a ketogenic diet. And they just verified, that they were in ketosis with elevated beta hydroxybutyrate levels. There are many, at least theoretical reasons to think that ketogenic diets will help with inflammation and cardiovascular disease. We have the what has now been shown by Dom D'Agostino and others, the anti-inflammatory cardioprotective potentials of ketone bodies themselves. So being in ketosis and having ketone bodies is probably anti-inflammatory and beneficial. We have the anti-inflammatory and cardioprotective effects of eliminating sugar, which I think we would all certainly agree with. Carbohydrate restriction outside of sugar, so non-sugar carbohydrate restriction, also has similar anti-inflammatory and cardioprotective effects, we think. And then there may be some benefits to omega-3 fatty acids. This is a more controversial subject, but most ketogenic diets are going to be higher in omega-3 acids, or possibly, I would add to this, lower in omega-6 fatty acids, which are going to improve the balance of pro-inflammation versus anti-inflammation in the fatty acid profile. And looking specifically at the effects of ketone bodies, we see that they have direct effects on the endothelium on modulating this inflammatory response in the endothelium. So one more trial that I found, this is actually very recently published within the past few months. This was a 6-month low-carbohydrate diet and looking at endothelial function and markers of low-grade inflammation. This is in patients with type 2 diabetes. And again, you can see in the red is the group that did the low carbohydrate diet, and they looked at IL-6 levels and CRP levels, both of which were lowered significantly. So we need more outcomes looking at that, but I think there's very strong potential on many levels for ketogenic low carbohydrate diets, therapeutic carbohydrate restriction, to modulate the inflammation that is the primary driver of heart disease. So once again, heart disease is about more than the lipids. And let's look at a quick case report that will demonstrate this. So LR is a 61-year-old gentleman. Back in 2016, he goes and gets a coronary artery calcium scan, and his score is 452. At this time, he's 214 pounds, BMI of about 28, seeks out medical advice, gets put on statins, gets told to adopt at first a vegan diet, which he does. He then kind of isn't able to tolerate it, like many people, kind of migrates more to the Mediterranean diet. And, loses some weight, feeling better, gets a repeat CAC scan done 7 years later, and now his score is 1,400. So goes up dramatically, despite being on a low-fat diet, despite being on statins. And this is the time that he engaged with me and joined my practice. At this point, he was mildly symptomatic. He's a very active gentleman, lives in California, surfer, was getting some chest pains when he was exerting himself, and we got a CT angiogram, which showed some moderate disease, 50%, 50 to 70% stenoses, not significant by CT-FFR, and he didn't want to proceed with angiography, with invasive angiography. So we put him on a very low carbohydrate diet. I even used the dreaded, C word that me as a heart specialist is never supposed to say, but it was a mostly carnivore diet, very low carbohydrate diet. His labs when he first came into the practice, and again, he had been doing a lowish carb diet, kind of Mediterranean diet at this time, but he had already lost, 20 pounds. His BMI still slightly elevated at 25.4. Fasting blood glucose looked pretty good, 79. A1C, very good, 5.1. But his insulin level is 13 at the time he comes into the practice. And again, within the normal lab value, but I think many in this room would agree too high of an insulin level. His CRP is moderately elevated, 2.9. One note about CRP for everyone, if you're going to use it clinically in your practice, the normal value for most labs is up to 3. And what they say when you actually look at it is they say between 1 and 3 is considered average risk for cardiovascular disease. Now, I don't know about you, but I don't want the average risk for cardiovascular disease. We want our patients to have below average risk because the average is not doing very good. And then above 3 is considered elevated risk. So 2.9, most doctors, you go to them and they see, oh, your CRP is 2.9, you're doing just fine. I would argue that we need to get CRPs lower. Ferritin, which is another inflammation-related marker, 319, normal being up to 300, so this is elevated. Now, by LPIR, he's not insulin resistant. His LPIR is less than 25. Homocysteine, another very important cardiovascular marker. Urge everyone to really be checking this on their patients. And again, 12.6 is in the lab normal range. Most labs, the normal is going to be up to 15. I would argue that any homocysteine level above 10 is a red flag, is a risk factor for heart disease. His triglycerides, not bad, but 119. His HDL is low at 47, although again in the normal range by the lab. LDL, this is now off of statins, which he had stopped a few months before starting to work with me, 149. And, most traditional cardiologists are going to say that's too high, but I'm going to say, well, it's not really that high. And then his lipoprotein A was slightly elevated, 38.5. The lab we used for this test, their normal goes up to 30. Other labs, the normal is up to 75. There are some different units between labs when you're looking at lipoprotein A, so just another kind of note of caution for all the clinicians out there. And then his LDL size showed him to be pattern A, which was good. So 3 months later, on his carnivore diet, he loses an additional 11 pounds, BMI now down to 24. His A1C goes down even further from 5.1 to 4.9, although his fasting blood glucose was higher on that particular test. His insulin level, most importantly, drops dramatically from 13 to less than 3. His CRP goes from 2.9 to 1. A normal value. His ferritin level actually goes up slightly. Triglycerides drop, HDL goes up, LDL goes up, but with the increased LDL, his LDL size actually goes up, and he remains in pattern A, and then his homocysteine level, we were able to get that down closer to a normal range. Now, being the rebel cardiac surgeon that I am, of course, I don't necessarily always stay within my lane. And, I'm thinking, you know what, this guy's diet wasn't that bad to start with. Where might this inflammation be coming from? As much as we talk about diet, it's not all about the diet. And, that old saying that the patient tells you the answer is very true. And as I'm talking to the guy, during our consults, and we're talking about, how much stress do you have? How do you sleep? And, he's talking about the stress from his home renovation. And we're talking about it and what went on? Why are you renovating your home? Oh, we discovered all this mold in our house. And so, it's not unusual that I screen my patients for mold and heavy metal toxicity. And sure enough, this guy was off the charts in terms of mold toxicity, ochratoxin. And then he, on his heavy metal testing, off the charts for tellurium. Do I have any functional medicine doctors out there who do heavy metal toxicity? Have you ever seen tellurium toxicity? Neither have I. So when you read the description of it, it turns out that this is one of the rarest elements on Earth. Tellurium toxicity is rare, mostly occupationally exposed workers, and he doesn't do anything unusual, but it's used in solar cells. So this guy lives in Malibu, California, right next to where they had all the fires. He was 2 or 3 houses from the fire line. All these houses that burned last year all have solar panels on the roof. And we are now in the process of testing his well water, but highly suspect that his water, he certainly was breathing in this stuff, and there's a good chance that his well water is contaminated with tellurium. And, how much of a driver of his heart disease is this? I don't know for sure. The mold toxicity has been going on, by his report, probably for many, many years. So maybe a very significant contributor. So he's currently doing some EDTA chelation. The mold has now been remediated, and we'll retest his levels in a few months to make sure that we've eliminated these sources of inflammation. But just a note of caution, always be thinking beyond the diet. The diet is a big part of it, but what else might be causing inflammation in our patients? So, in summary, heart disease is not all about the lipids. Inflammation is a very important part of the development of heart disease. We should be addressing inflammation in our patients and testing for it, and then mitigation. And, if you have a patient, you put them on a low-carb diet, they're doing well, their inflammation markers perhaps are still staying elevated, think about more unusual sources of inflammation. Low-grade chronic infections, things like chronic Lyme disease. I've now, uncovered in a few of my patients, and heavy metal and mycotoxins as well are not an uncommon finding in my patients with cardiovascular disease. Thank you. Our practice, telemedicine-based. We see patients throughout the U.S. and even internationally. If anyone is in need of advanced cardiovascular support, what I say is, I really don't even want to see all the patients who, just need to lose weight and on a low-carbohydrate diet. There are so many people in this room who do that so well. But when you get into the advanced cardiovascular issues, we're available, and feel free to reach out on social media and contact me at any time.
Thanks, that was great. Alan Schaefer, Albany, sleep, pulmonary, and obesity medicine. Can you talk a little bit about the CAC and your patient example? I don't recall, did his CAC go down? What is the natural history of atherosclerosis, calcified plaques, and what can we expect going down? Because I see a lot of patients with non-zero CACs, and I wonder what to think. Thank you.
Yeah, so I think the two key concepts on CAC scans that I'd like everyone to understand are, first of all, it is a test that should be repeated serially. It's not a one-time screen. You want to know the progression of that patient's disease. And certainly we know from the data that the faster your CAC score is progressing, the worse your prognosis is. So if we can slow progression of coronary artery calcium scores, that lowers your risk of future events. And that's really the goal that I give my patients. Let's slow the progression. I do see some reversal. I've had patients whose scores have gone down 15, 20%, and there's always a 5 to 10% sort of variance in these things. So we're still trying to understand what to make of that. The more advanced CT angiograms now can give us more detail about soft plaque versus calcified plaque, but they're more expensive, they're more radiation, they involve dye. So in my practice, I use the CAC scan. I do them annually with my patients, and we do track that progression, which is very important. So even if you have a non-zero score, don't despair. You just need to stop it from getting worse.
Thank you, doctor. That was very informative. J.J. Malvarez with coach. I'm a coach, a ketone fasting coach. Have you come across situations where your patients show high CRP and it happens that they're doing okay, but if you dig a little bit more, they are gym goers. They spend 4-5 days in the gym. And that seems to be the case why the CRP is elevated.
Yeah, doing a particularly strenuous workout, heavyweight workout, or a long cardio session will raise your CRP. That's usually pretty temporary. It's usually like a 12 to 24 hour. So if we have a patient and their CRP is elevated and we're not, we don't know why, we can't really find another cause, but we suspect it's, maybe they just working out hard. I'll just ask them to not work out hard for 2 days before they have the blood work drawn, and that should give you a good reflection of baseline CRP levels. It's HSCRP, highly sensitive CRP that we use these days, and it is highly sensitive to all sources of inflammation. So I've seen things like, moderate sunburns that can dramatically increase CRP. Hard workouts can dramatically increase CRP. Of course, if the patient has been recently ill, with any sort of infection, viral illness, that can raise the CRP. So like every other lab test, it needs to be interpreted in context. But yeah, you need to be thinking about why is this CRP elevated? And the patients who come to us that aren't on low-carbohydrate diets, that's the first target. But like I said, it's not the only target.
Thank you.
Thank you.
Hi, I'm Crystal. I'm a family NP from Denver, Colorado. I'm just wondering how frequently you order those mold and heavy metal testing. Is it just for your patients who have that persistently elevated inflammatory markers? And do you think that patient's ferritin was high because of that ongoing inflammation?
Yeah, so I do think the ferritin was reflective of the inflammation. And again, I guess another kind of mistake I sometimes see being made is people with high ferritin levels, the answer will just be go donate blood. And yes, that brings down the ferritin, but it perhaps doesn't address the underlying inflammation. So persistently increased inflammation markers is one of the things that usually triggers me to order mold and heavy metal testing. This patient, it was also the history. So you do want to ask about exposures. And sometimes it's obvious, anyone who's dealt with mold toxicity, mold issues, many times the patients don't realize it. And I have had other patients who have had unexplained persistently increased C-reactive protein levels. We get the mold testing. they come up positive, and then they start searching for where is the mold, and they find it in their house, in their office, whatever it might be. So I think I don't do it on all my patients, like on entry into the practice, but if I'm seeing persistent inflammation, I've started testing for it.
Thank you, that's helpful.
Can you please comment on the role of occult periodontal disease in persistently elevated CRP with no other good explanation?
Yeah, great question, and I think it is an important contributor. It's another, area of questioning that I go down with my patients. What's their dental history? Do they have unresolved periodontal disease? Have they had previous root canals that maybe they have, abscesses from that need to be screened for, finding a good dentist who knows how to look for that. Very important. I've actually started to interact a lot with the periodontal community. I'm actually going out in March to talk to a group, about 300 periodontists who are interested in metabolic disease. And that's perhaps for Doug, something we should talk about, starting to reach out to the dental and the periodontal community, because they're oftentimes recognizing all this, from the mouth, and then they need, their patients to start doing, carbohydrate restriction to help with the periodontal disease. So that's another community that we should be reaching out to. All of you in practice, reach out to your local dentist, reach out to your local periodontist, maybe get together for a discussion and say, how can we work together? You're seeing it as periodontal disease. We're seeing it as, heart disease, obesity, insulin resistance, and all of this. Great question.
Yeah. We've actually had a dentist back in West Palm Beach days, but that was a long time ago. It's high time we got another one. So.
Yeah, definitely so.
Eric Westman, Durham, North Carolina. Thank you for your work and a wonderful talk. I was impressed with Ben Bickman's sleuthing skills to find an obscure paper on Sam Feltham's N-of-1 trial. Why did you miss the Verta Health study, which I think is the best evidence of inflammation reduction? And it's Athenarian. It's a subsequent publication from their diabetes.
That's a very good question why I missed it. Maybe those results are being suppressed.
Okay, no, I'll send it to you.
Great, yeah.
It's the best evidence so far, I think. I wondered if it was because it wasn't randomized. And I think the results are still the best we have. But anyway, changing subject and all, have you ever seen the CAC score go down?
Yes, so I do now have a handful of patients that we've seen lowering of CAC scores on the order of 15 to 20%. And my protocol is pretty straightforward. Therapeutic carbohydrate restriction and get good sleep and manage your stress. And I use supplements like vitamin K2 and nattokinase. So we have a few patients now, but I tell people as long as you stop it from progressing, you're doing fine.
Well, and that's great to hear, because it's a bit of a Pandora's box, isn't it? If your CAC is 0, there's pretty good evidence you're low risk. But if it's not 0, it can mean you have really bad disease. Can you please publish those or present those at a meeting like this one, where you can actually not have to have peer review and all that? Because people come to me assuming the low-carb diet's going to fix everything, including the CAC score. I don't really see that, and I'd love to know what your protocol is. Please present us.
Yeah, I think it fixes it. It oftentimes fixes it in the sense that it stops progression. And so I think we need to recognize Arthur Agustin and others have published the data showing that as long as you stop the progression, you're lowering that patient's risk significantly. So patients want they want, and I'm always, I'm upfront. I'm saying your score is not going to go back to 0. If you're starting at 400, certainly if you're starting at 1,000, you're not going back to 0. But if we get you back to, you start at 1,000 and next year you're 900, great. If you start at 1,000, next year you're 1,000, great as well. And so it's helping patients to understand that we may not be able to undo damage that has already been done, but as long as we stop doing the damage, that's going to stop you from progressing to a clinical event.
Hi, John Laspina, Boca Raton. Dr. Westman asked my question, so I have another question about the CAC score lowering. So we'll ask that first question. How much lower have you observed? You said you saw them lower.
Yeah, so the biggest lowering I've seen in my practice is like 15%, from roughly 1,000 down to, 800 range, 850 range. But like I said, the majority of the time what I see is stopping the progression.
Stable.
Yeah.
Okay. And then my question is atrial fibrillation. What
Yeah.
are your observations? What have you seen with people going on a ketogenic, a low-carb diet and either halting or reversing that without having to have surgery?
Yeah, another great question. And, again, we know that there's a strong interrelationship between inflammation and atrial fibrillation. So I have seen positive results in terms of lessening the frequency of symptoms in people that are having paroxysmal atrial fibrillation. In general, when you're dealing with atrial fibrillation, the shorter you've been in it and if you're paroxysmal, meaning going in and out of it, versus persistent, always in it, it's easier. You tend to see better improvement in those patients that have been in it shorter duration and are paroxysmal. And I have seen patients who have improved their atrial fibrillation. At this point, I say it's certainly worth trying. Certainly no harm. I don't see anyone's AFib get worse when they adopt therapeutic carbohydrate restriction.
All right, thank you.
Stuart Weinstock, Miami, Florida, psychologist. Dr. Ovadia, I read your book. Fantastic contribution. I love it. I send it as a gift to all my friends that really need to upgrade their self-care. My question is a subject that's never broached in a cardiologist's office, and I'll ask you it. What recommendations would you have in terms of nutritional supplements that might enhance or help with the cardiovascular disorder that people might have blockages? Are there any nutritional supplements specifically that you would recommend?
Yeah, so the two that have some evidence behind them in terms of nutritional supplements for patients with atherosclerotic plaque, I would point to nattokinase and vitamin K2. Now, a animal-based low-carbohydrate diet should be pretty robust in terms of vitamin K2, but I don't think there's any harm in adding it, and I typically will with those patients. Nattokinase, which is a fibrinolytic enzyme, helps to break down blood clotting. Makes a lot of sense that that's going to help with cardiovascular disease. And there is published data showing reduction of carotid intimal medial thickness with nattokinase. You have to have adequate doses. The biggest trial that looked at it, 2,000 units a day was not enough. 10,000 units a day was enough. We don't know where the cut point is in between. So nattokinase and K2 are probably the two most common supplements that I recommend for people with atherosclerotic cardiovascular disease. Coenzyme Q10 is probably something else to throw in that discussion. Certainly if your patients are on statins, I don't know why it's not mandatory for them to be on CoQ10. It just, for whatever reason, the cardiovascular community has not accepted that concept. And but I certainly recommend for any of my patients that are continuing on statins, CoQ10, and probably beneficial. Stephen Sinatra and others, have shown some have at least promoted the idea, and I think it does make sense. And again, it's a low-cost, low-risk intervention, so CoQ10 is another one that I'll often recommend for my patients.
Thank you. I appreciate your presentation. It's refreshing to meet a cardiologist who's into nutrition. Very, very helpful. Thank you.
Thank you.
Question about a little bit of nuance for CAC. Regression is great, awesome. Progression, the data suggest are bad, pretty clearly. Yet, people say that statins results in plaque calcification, which is a more stable plaque, right? Less risk of rupture. So patients who are on a statin who have progression of CAC but are doing everything else right with TCR, with reduction in inflammation, do you have any nuance for how you interpret a progression in people who are on statin therapy who may have calcification and potentially stabilization of plaque?
Yeah, so that is a fairly controversial, this concept of plaque stabilization with statins is kind of it was kind of developed with some backwards thinking as best as I can reconstruct, because you're right, the data does show fairly clearly, although not in every trial, but in a lot of trials, patients on statins have higher rates of progression of coronary calcification, and this then led to this discussion that we're stabilizing plaque. It's real interesting when you go through the literature about things like plaque rupture and this concept of that we go from the fatty streak, the early atheroma, and then we go to, we get soft plaque that then becomes calcified plaque, and, somewhere in between you can have plaque rupture. It's actually not that simple. And there have been some studies where they looked at plaque progression now with CT angiogram. And again, this is newer because we're really just getting to the high fidelity CT angiograms that we can really actually now differentiate, the thickness of the fibrous cap that can help us to determine, are plaques potentially stable or unstable. There are some blood markers that are being looked at and investigated along these lines as well. Things like LPPLA2, also known as the plaque test, PLAC test, that is supposed to help differentiate between unstable and stable plaques. And I've had, I would say I'm mixed use of it in my practice because there are a number of these markers, myeloperoxidase being another one, and oftentimes you check this whole panel, so ADMA, SDMA, myeloperoxidase, LPPLA2, and two of them are up and two of them are down, and you're like, okay, what do we do with this? In terms of the CAC scan, again, progression is important, and I do think any progression is a bad sign. Now, even within progression, though, it gets more complicated. And so, I encourage people, and, if you're able to do this or get a good radiologist to do it for you, you actually want to look at the pictures, because there's a difference in progression if that patient has developed new areas of calcification versus previous areas of calcification that have gotten denser calcium. That's a very different scenario as well. So if you have the capability of doing it yourself, or if you can partner with a good radiologist that can actually go and look at those two scans next to each other and figure out where is the progression, I think that's a very important metric as well. And that's something I do with my patients.
Thank you.
So.
Milton Swaby, physiatrist, Ohio. So I learned at this meeting that coronary artery calcium score and that plaque can be reduced with berberine. Do you have any experience with that? using berberine?
Yeah, so berberine, which is a natural metformin analog, I think it's okay. Certainly if the patient comes to you and they have an elevated A1C to start with and they don't want to take metformin, while they're getting started on their carbohydrate restriction, maybe berberine is useful. I don't use it a whole lot, to be honest. I think, we know the most effective tool for reducing A1C and improving insulin resistance. If someone needs a little help doing that at the beginning, I think metformin is a pretty safe drug to use, and it is effective. Berberine, I've seen, is not as effective in the, and when you look at the studies on berberine, the reductions in A1C and improvement in insulin sensitivity are more modest than you can get with metformin. So I just tend to use metformin if needed for the patients. But certainly, many of my patients come to me on a host of supplements for this purpose: alpha lipoic acid, berberine, some of these other things that are improve glucose, control, disposition, but ultimately, I don't think it's a big part of the puzzle.
Okay. Diane, dietitian evolved. The kinase, Lakeworth, the kinases, I am wondering about how you monitor the blood thinness. Is it the same that you would do for the blood thinning drugs?
No, so the ProTime or INR won't detect effects from nattokinase, lumbrokinase. I monitor fibrinogen levels in my patient is probably the best way to do that. And especially in the patients with elevated fibrinogen levels in the presence of heart disease, I think, it's important. And those are patients, oftentimes I'll suggest aspirin as well. The trials on aspirin in terms of prevention of cardiovascular disease have been negative, and it's no longer recommended as for routine, for primary prevention of cardiovascular disease. But in patients with known disease, and especially in those that have elevated fibrinogen levels, nattokinase and aspirin are usually going to be recommendations that I make.
And just so people don't freak out, don't worry, I don't usually use something that strong in my practice. People usually come to me, and then I just wanted to know that information so I can relay it. Thank you so much.
You're welcome.
Good morning, Dr. Phil Proctor from down here in South Florida. So based upon your YouTube videos, I went and got a CAC test, and I was told that it couldn't be read because I've got stents. Is there another way besides the CAC score to find out what's really going on inside?
Yeah, so, and that's another great question and one I deal with often. So the CAC scan, can be done in people with previous stents. The automated scoring, algorithm may not work because the area of the stent is going to show up as a calcified area oftentimes. But I'll still oftentimes get the scan to look at the other areas. And again, when you work with the radiologist, they can go in there manually oftentimes and kind of get you a score. Or it's just a visual thing. Again, I have the patients, I get their images and I look at them and it's like, okay, let's look at the areas outside of the stent, and then let's see what's happening with those over time. If you're concerned beyond that, then the CT angiogram is a great option, and I'll oftentimes use that. And we have the newer, CT angiograms that kind of have, they call it AI, but it has more advanced computer reading of it that can start to tell you plaque characteristics, and they actually can show you plaque thickness at each point in the blood vessel. And so in a situation of someone who has previous stents, it's not unusual that I'll use that test as well.
Okay, so perhaps I can talk with you about that offline?
Yep, definitely.
Thanks very much.
Yeah.
Appreciate it.
So I have a study somewhere stashed on where they determined that vitamin C with magnesium chloride and magnesium oxide together seem to help to reduce plaque. Your opinion on that?
Yeah, so vitamin C, the so-called Pauling protocol, which has certainly been promoted for the treatment and prevention of cardiovascular disease. It's high-dose vitamin C. So one of the limitations is getting patients to tolerate the high-dose vitamin C, which can oftentimes have GI side effects. And then finding appropriate forms of vitamin C to deliver in those high doses can be challenging. And then in the Pauling protocol, Dr. Pauling, and this is Dr. Linus Pauling, combined it with proline, lysine, and I think one other thing. But so I've had a few patients use it. We've seen mixed results. It's been reported to lower lipoprotein A levels, and again, seen mixed results. Patients with elevated lipoprotein A, we really don't have a whole lot to offer them at this point, except avoiding inflammation. This is another key concept, that lipoprotein A has been shown to be problematic in the presence of inflammation. But when you have elevated lipoprotein A without inflammation, it's not as clear that it's problematic. So I've had mixed results with vitamin C protocols. I don't use it routinely in my practice, but I do have some patients who, we do that for.
Could you quantify high?
The dosage of the vitamin C?
When you say high dosage?
Yeah, the Pauling protocol, I believe, is between 6,000 and 12,000 milligrams a day. 6 grams, 6 to 12 grams a day, so it's very high dose vitamin C.
Yeah, that particular paper had about 1,500 and again, supplemented with two types of magnesium. Thank you.
Yeah.
Eric Westman, Durham, North Carolina. In my clinical practice at Duke, I get a lot of referrals. The orthopedic surgeons, the cardiothoracic surgeons have people who need heart transplants and they're too heavy. The cardiothoracic surgeons send me their patients. You're not a cardiologist, you're a cardiothoracic surgeon. The Sugar Busters diet back in the day were a couple cardiothoracic surgeons in New Orleans who wrote a book. Is there something different in the training of a cardiologist versus a cardiothoracic surgeon that makes you more open and maybe them less open to what we're doing?
I think it's when you actually lay your eyes on the disease every day. I see these plaques and now I say it's obvious, but I admit that, 10 years ago it wasn't, I didn't see it, but like many of us have said, once you see it, you can't unsee it. And you see that it's not cholesterol that's the problem there, and that there's more going on. And you see the heart encased in visceral fat. And you're like, there's more going on here, and I think, the frustration that I developed was that, I knew that, okay, I was putting a Band-Aid on the problem. I'm doing the bypass surgery, and the patient gets better and, oftentimes can be life-saving, but we're not addressing the underlying root cause. And so if you have that desire to address the underlying root cause, you do something different. And so I'm glad to hear that some of the cardiac surgeons at the institution are starting to pay attention to this. Quite frankly, a lot of my colleagues, cardiac surgical colleagues, are very open to this. Many of them are eating, ketogenic low-carb diets. They're like, yeah, we know that works. We just don't talk to our patients about it. We can't talk to our patients about it. And I'm like, yes, you can, And so, excuse me, I think it is important. I think we as the cardiology community in general, what I'd like to see, yes, we continue to have the fight, our lipids, what is the role of the lipids? But let's get beyond that. let's just agree it's more than the lipids, and let's start addressing these other factors. And, I've given grand rounds a few times. I have gotten positive responses with, let's pay attention to insulin resistance, let's pay attention to inflammation, and I think we can start to bridge this gap. Ironically, I was introduced to this whole world at the Society of Thoracic Surgeons meeting. Gary Taubes, for whatever reason that I still can't figure out, and honestly Gary doesn't even know, was some reason invited as the guest speaker. And this is when he had just written The Case Against Sugar, and that's where I was first introduced to all of these concepts. And I do kind of sit back and think of, the 1,000 or so cardiovascular surgeons that were in that room, how many have kind of gone down a similar journey as me. But there is hope. We can work together with them.
Hi, thank you. Ian Lake, I'm a primary care physician in the UK. Just to back up your CAC scan data, this is not directly related to CAC scans, but there's a guy in the UK called Tony Royle, R-O-Y-L-E. I don't know whether you know of him.
Yeah.
He spoke at a public health collaboration conference in the UK. He was an airline pilot, had a heart attack while he was flying the plane, came back to the UK, had a CT angiogram which showed significant stenosis in one coronary artery and just sub-threshold for stents for two others. So he elected to have one stent, went on his own journey of discovery, came off all of his medications, decided he would do an Ironman about 6 months later or whatever. He ended up doing a sort of Forrest Gump, running marathon after marathon after marathon. He became one of the top 10, in the top 10% for Ironmen in his age group in the world, and subsequently had a second, it was a coronary artery flow rate test, which is not quite the same as CAC scan or a CT angiogram, but it showed it was completely normal and there was no evidence of any calcification of his arteries. So just an interesting observation of an N equals 1, but shows what's possible, really. Yeah, definitely so. And that's another thing to keep in mind, that, coronary calcium, even when you get CT angiograms, like the example I showed, that guy had a 50 to 70% stenosis in one of the blood vessels. And the traditional thinking is, we got to get a stent in that. We know from the stent data that, treating stable angina or asymptomatic patients with stents is of no benefit. The only benefit of stents have been shown in patients with acute events or unstable anginal symptoms. So even if someone has a blockage, and I do have a few patients in my practice who were working through this, that have significant blockages, have symptoms, they don't want stenting, and we've put them on therapeutic carbohydrate restriction. They're feeling better. Their exercise capacity increases. We're waiting on follow-up imaging on a lot of those patients, and it does get kind of complicated because what imaging do you look at? So CIMT, easy to do. You can do it on a daily basis if you want, but is it really reliably showing you what's going on in the coronary arteries? The advanced, CT angiogram with the flow test is the best way to look at, coronary arteries non-invasively, but it's a very expensive test. It involves dye, it involves radiation, so we can't do that as frequently on patients. And so we get into the situation where, we don't have that great way of assessing on an ongoing basis yet. And of course, we know the blood markers are of, variable to no use. So that's what we're up against. And that's where it's just got to work with your patients individually. Thank you, Ian.
Hi, I'm Lisa Huey from Omaha, Nebraska. I was on a statin for 10, 20 years. Decided to try low carb about 6-8 months ago, and decided to go off my statin at that time. I have a functional med doctor who was very concerned about my cholesterol because subsequent blood tests showed that it was elevated. And pretty much told me that if I was committed to being off of this statin, that I should get a coronary calcium scan. So I went and I did that. Of course, I had to pay for that out of my own pocket. But yes, my question is, my scan came back with a score of 1. What should that tell me about how my high cholesterol affects my arteries? I guess that's my question.
Yeah, and that's going to be age dependent, and this is where the serial scanning comes in. Any score different than 0, and if you get a score of 1, you always want to make sure it was actually a real score, because sometimes the computer just picks up a little blip that isn't actually calcium. But any score greater than 0 just shows that your body has the capacity to form plaque. And has started that plaque formation. And, the younger you are when that occurs, the more of a warning sign it is. But this is where the serial scanning, I think, becomes useful in understanding your progression over time. And then when you get into the whole statin and lipids discussion, I'm going to mostly leave that to David to do his usual excellent review of that. But,
Which David?
David Diamond standing behind you there. But you want to, you want to understand your lipids. What I tell people is it's not about the quantity of your lipids, it's about the quality of your lipids. And I think that's what's really important, and that's what we want to understand, and that's where we get into things like, NMR testings, particle sizes, oxidized phospholipids, that type of testing, I think becomes important.
Yes, hi. The reason why I asked, my name is David Nabert from Statesboro, Georgia, and I'm a cardiologist, a cardiac electrophysiologist. I'm also boarded in nuclear cardiology, and I'm a very recent metabolic health practitioner. So my question to you is, what do you do, and what is your big overall plan for converting more people like me to this ketogenic space, meaning cardiologists? I've learned to be exceptionally cautious in how I approach things and rather circumspect.
Yeah, so, I would say I use a mix of caution, but I think also we need to wake up the zombies. And, so one of my tactics is often the sort of, how's that working for you? Lipids have been, lipid lowering has been the primary mode of therapy now for 40 years. And what's happening to heart disease rates? They're going up. So what are we doing here, guys? That's kind of the question I start to ask my colleagues more and more. And like I said, I give grand rounds. I talk about insulin resistance, inflammation. I show the data. It's like, okay, you want to focus on lipids, fine, but realize that LPIR has 10 times the predictive value that an elevated LDL-C does. So let's address that, and maybe we can start to actually have an impact on cardiovascular disease. And I do find that they're open to that messaging.
David Diamond, University of South Florida. So Philip, I have just great admiration for you. Spectacular talk, and it's a pleasure to work with you on Health Quest. I have maybe a difficult question for you. You said your patient's LDL went up, but not too high, which of course piqued my interest. At what point would it have been too high? For example, if he had been a lean mass hyperresponder and his cholesterol, his LDL was 300 or 400, what would you have recommended to that patient?
Yeah, what I recommend to those patients is, kind of exactly what I've been talking about. Let's look at your lipid quality as opposed to the quantity. Let's look at what's happening with the disease of interest. So serial CAC scanning to actually know what's happening with the disease of interest. And then, and then we can go from there. We know that there are ways to modulate the lean mass hyperresponder response. Tro and Rob Seifus and others have shown, 25, 50 grams of carbs a day is oftentimes enough to bring these patients' LDL down dramatically if they're worried about it or if we have reasons to think we're going to be worried about it. And of course, we're getting the lean mass hyperresponder data now. Dave published or presented the initial data. Matt Budoff presented the initial data from Dave Feldman's study a couple of weeks ago that will be published soon. And we're in the process of getting the follow-up scans on those patients. So we're going to have more data. But basically, like I said, the discussion becomes quality of cholesterol versus quantity and what's actually happening with the disease of interest.
So I guess what you're saying is we're still in a state in which we don't really know if very high LDL, as in the lean mass hyperresponders, is harmful or even helpful.
Correct. And, we also have to acknowledge that there's an in-between state here. There are people who are not lean mass hyperresponders, but their LDL goes up on, low carbohydrate diets. Oftentimes I'm dealing with the complicating factor of we're simultaneously coming off statins and instituting the low carbohydrate diet, so which raised your cholesterol? And like I said, the discussion really, I think, needs to refocus on cholesterol quality, and let's look at the disease that we're actually interested in instead of biomarkers that may or may not be actually related to it.
Thank you, Philip. Everyone stay around. This is what I'll be talking about this afternoon.
Hi, Lester Hightower, Jacksonville, Florida. You've talked a lot about serial CAC scanning, which makes all the sense in the world to me. It seems to me that CAC scanning is sort of very hit and miss across the country. I have friends that are in some markets where it's like an over-the-counter thing. You walk in, $75 later, you have a CAC scan. Where I live, it seems almost impossible to get a CAC scan as a patient. I'm curious, do you have any resources for patients that like to get a CAC scan but sort of struggle to find a resource to have that done?
Yeah, so, excuse me. I do find that the scans are ubiquitously available, meaning that almost every imaging center that has a CT scan now offers them, and usually at fairly low cost. They usually kind of use it as a way to get people in the door. So I find, at least here in the U.S., they are widely available, but you need a doctor to order the test for you. It's still the limiting factor. There's really no reason that I can think of that doctors shouldn't order these scans if patients are willing to pay for it. The understanding is insurance won't cover it, but usually it's under $150. And if your doctor is resistant to it, it might be a sign, one of those signs that it's time to find a new doctor. I'm not shy in telling people that.
Hi, Michael Wood from Seattle. I have a question about A1C management. So I presume you have a lot of pre-diabetics that you work with. And let's say you go from a 6.3 to a 5.7, 5.8. Are you trying to lower it even further? And if you are, how are you? And let's assume that your folks are staying under 50 or 30 grams a day, and it's still stuck at 5.6, 5.7, 5.8. Are you looking to lower it any further? And if not, or if you are, why? And what methodology would you use? By the way, Ted Naiman is my doctor, and I met with him last month, and he told me that the only way I will be able to lower my A1C further is if I lose more body fat, and I have a 24 BMI. Yeah, and I would kind of agree with that. I think how low we need to go on A1C. Of course, I'm always happier when I see a 4.9 as opposed to a 5.6. The case I presented, that guy was able to go even lower. Do we need to? I would say not clear, and again, what can you do beyond it? If you're doing therapeutic carbohydrate restriction, you can play around with fat to, protein ratios some, Metformin, berberine, I don't find really helps much in those patients. I don't really see that it lowers A1C more for people who already have a normal A1C. So I'm usually pretty happy if it's 5.7 or below. And I think there are probably genetic factors and,
I guess, again, this is where the history comes into play. Patients that have struggled with obesity, have had insulin resistance, are different than patients who haven't had that. And so I don't worry too much about getting the A1C necessarily down to 5. I'm usually pretty satisfied at 5.6, 5.7.
Thank you.
Okay, we got like 3 minutes left. Let's try and do one quickly.
Mine is fast. Good afternoon. Good morning. Xiomara Espina from Miami. Dr. Ovadia, you mentioned about heavy metal testing. Which test do you recommend the most? The blood, urine, saliva? Do you have any recommendations? More accurate one?
No, I tend to use the urine testing just because it's easy, quite honest, for patients. And I think it seems that it has the most data. A lot of people talk about hair testing. I'm not sure there's a whole lot of difference. I think the urine seems to do a pretty good job of picking up the significant cases, I would say. And then, of course, the question becomes what to do about it. I think identifying source is probably the most important thing in starting to mitigate it. Chelation therapy, and of course this is a whole nother topic. Chelation therapy has been shown in an NIH-sponsored trial to have some benefit for people with cardiovascular disease and diabetes. In non-diabetics, it didn't show a benefit in that small trial. The follow-up trial never got done for reasons that aren't quite clear, which I think is a big problem. So I think if you identify heavy metal toxicity in a patient with cardiovascular disease, it makes sense to me that chelation therapy, it can be beneficial in that situation. But honestly, we don't have data to say that for sure. So
thank you so much.